Hello and welcome to the Global Virtual Aesthetic Summit. My name is Dr. Robert Kessler. I have been board certified in general surgery, plastic surgery, and then went on to do a fellowship in facial aesthetics. And I have a practice for the last 20 years in Newport Beach, where I do primarily aesthetic surgery. We're going to be talking today about facial volumization with hyaluronic acids primarily. And we're talking about the aesthetics first, followed by the relevant anatomy. As the rise of filler usage has gone up, so has the incidence of complications from filler, so understanding the anatomy is absolutely critical. And then lastly, we will go through clinical demonstrations of techniques that I find successful in my practice. The more we educate our patients, the more they understand and the more they accept our treatments. And I find this to be incredibly helpful, and I use it on a daily basis with my new filler patients. I also find it really helpful to explain how I go about doing things that I like to do. One of the things that I like about this image is that it is a mother and a daughter. It is not computer morphing technology, and the reality of things is she almost looks like she cloned herself. And so when I talk to my clients, I show them this picture and I show them what are the relevant facial changes. And one of the things that I always point out is how much more understanding we have about the facial aging process in the last 10 years, thanks to the insights of individuals like Dr. Val Lambros, to the anatomic studies of Joel Pessa and Rod Rourke, and also now from a safety standpoint, the anatomic studies of James Zinn and Chris Zudek. So we'll be talking about each of those things. But if we look at this image, what we see in the youthful face is no transitions between structures such as the eyelid and the cheek. The nasolabial fold ends above the commissure of the mouth. The jawline is a smooth and continuous curve. And so the youthful face is smooth and continuous curves. As we age, what we see is the 7 facial fat pads in the cheek behave very differently. The 3 that are at the nasolabial fold become prominent at the marionette line and eventually become the jowl, actually keep their volume. And so these 3 fat pads are most likely the same size. It's the 4 fat pads behind there that lose their volume. And as they lose their volume, the skin doesn't tighten. And so what we see is the illusion that the face is sort of falling forward and down. All right, now there are other bony structural changes that are going on, but again, this is a soft tissue filler course. So what we're going to be talking about is how do we address these areas. Although she does not demonstrate it, there is always some degree of temporal wasting, so we're going to be talking about the techniques for injecting in the temporal area. Prominent fat pads are a surgical correction, but tear trough volume loss is a hyaluronic acid filler correction, as is the mid-face, the superior nasolabial fold, the pre-marionette region, the pre-jowl sulcus. We also see very clearly how the lip elongates. The architectural definition of the white roll and the cupid's bow gets effaced, and so lips can be enhanced without creating a volume augmentation per se. That we can talk about as well. We're going to transition now to vascular anatomy and safety. In terms of safety, there are 2 great reference articles which I will provide at the end of this talk out of the University of British Columbia by Dr. Bolesny. She did a retrospective review prior to 2015 and found that there were 98 reported cases of blindness associated with volume augmentation of the face. Interestingly, at that time, it was predominantly fat that was being used and causing the issue, but a follow-up study from 2015 through 2018, the number of blindness cases was actually 48. 50% of the last prior known experience within the last 3 years alone. This is directly related to the significant increase in the use of fillers, and interestingly enough, now the embolic phenomena or the vascular occlusion phenomena is majority hyaluronic acid induced, about 81%. the areas of distribution of where the emboli were generated from has also changed. Previously, fat injection, the glabella area was the dominant area. Today, as of the recent Leslie study, showing that the overwhelming majority, probably about 56%, were from augmentation of the nose, 27% were augmentation of the glabella, about an 18% incidence of augmentation in the forehead, and then scattered augmentation from the area of the nasolabial fold and even temporal. And we're going to go over each of these because the primary way that we can avoid these complications is understanding the anatomy. Facial anatomy is incredibly variable, and so even a true understanding of facial anatomy doesn't prevent the likelihood of having an embolization. However, the more knowledge you have, the safer the injection technique is. And we'll also talk about some adjunctive things that can be done in addition to understanding the anatomy. So if we just start here, and we'll just start up at the top and work our way down. The supratrochlear artery is palpable at the notch in the medial brow, and there is the supraorbital artery that they share a common origin from. These track back to the central retinal artery, which then go into the ophthalmic artery. Here we see the supratrochlear artery coming deep, but then coming into a very superficial location in the glabella. And so what we know is anywhere between 11 and 18 millimeters from that supratrochlear notch, we are going to have a vessel that is about 1.5 millimeters deep to the surface, or superficial to the skin. So superficial injection has to be done very, very carefully. And so the needle should be in or just below that subdermal level. We also know that the dorsal nasal artery is a branch, which then comes down, sending branches to the tip. It anastomoses with the angular artery, and so what we are seeing with these issues in this glabellar and central facial area is these vessels can be cannulated. An interesting study has shown that the volume of the lumen from the supratrochlear branch to the central artery, central retinal artery, is only 0.08 milliliters. A small fraction of volume and a minimal pressure that actually can overcome the systolic arterial pressure, leading to retrograde flow into these vessels. Interesting and concerning part of this is injury to that retina has been studied, and we see already within 15 minutes irreparable damage, although we previously had thought we had about 90. And we'll talk about the pulsed hyaluronidase infusion as a safety mechanism to deal with that. But primarily, the way that we avoid this is palpating the area of the artery that we are most concerned about, maintaining compression while injecting, watching the skin for vascular compromise, and identifying it early so that these maneuvers can be undertaken. Coming forward with the facial artery, we know that the nature of the angular artery is quite tortuous. It can track medial to the nasolabial fold and is a branch of the facial artery. Areas that we consider stable landmarks are the areola height, 3.5 centimeters from the midline, is an area where we routinely find the angular artery. We'll talk a little bit later about how the deep piriform space and the premaxillary space are safe zones with cannula injection in this area, and 1.5 to 1.7 centimeters from the commissures, where we also know the angular artery is found. The angular artery is intimately involved with the nasolabial fold and can actually cross medial to it in the mid portion of the nasolabial fold. Here it runs at a depth of approximately 5 millimeters. So superficial injection in either a tangential or hash mark. The superior labial artery branches from the angular artery and runs just inferior and superficial to the white roll, making this area incredibly vulnerable during augmentation for embolic phenomena, backfilling into the angular artery. So superficial technique at that white roll for vermilion enhancement is my preferred technique. Augmentation in the vermilion is done with cannula through a lateral port, and there is a septum, and we can fill by placing the cannula as it easily passes both anteriorly into the midline and posteriorly. You can go across the entire labial artery, branches off of the angular artery or facial artery at this point, and runs in the, or parallel deep to the ligamental sulcus. This is actually deep to the orbicularis muscle, which allows for superficial augmentation of the marionette region. And even the facial artery emerges just distal or lateral to the attachment of the osteocutaneous ligament that are visualized here. So that is in this course here. Medial injection at both the deep periosteal plane from the midline or from a slightly paramedian injection port is ideal for jowl augmentation. Superficial or subcutaneous injection in this area is actually also safe to achieve a nice contoured jawline. As I mentioned earlier, there has been blindness associated with temporal augmentation. The understanding of the anatomy in this area is very important so that this also can be avoided. We know that the anterior branch of the superficial temporal artery anastomosis with a lateral branch of the supraorbital artery. And it is this communication which can lead to retrograde flow in the supraorbital artery, which then can back into the central retinal artery. This area is in the subcutaneous plane. Deep temporal injection, as recommended by Swift, is safe, as I'll describe later in this talk. However, subcutaneous injection with cannula techniques can be done in this area and maintain safety by awareness of this anatomy and injection techniques such as low pressure injection and retrograde injection or injection of products while withdrawing the needle. Last area we're going to speak about is the infraorbital vessels, which also richly anastomose with the angular artery. But in tear trough augmentation, there is a branch, it is the palpebral branch of the infraorbital artery. This runs immediately cephalad and then parallels the eyelid margin into the medial canthal area and the medial soot compartment. This anastomosis with the angular artery, which can be found approximately 1.3 to 1.7 centimeter inferior to the medial canthus. Although the incidence of these complications are extremely low, they are real and there are precautions that we recommend you take. The first and foremost is with central facial augmentation. Cannula placement is a safer technique than sharp needle, as we know the rich anastomosis of these vessels within this area has been responsible for the blindness and the complications previously discussed. Whether or not epinephrine is used in that area is recommended by some. This can camouflage the blanching effect, which is one of the first signs that we see, and so this I would fall in the category of user preference. Compression of the arteries of concern while injecting is a technique that I personally think is very useful in my practice. The use of the injection techniques with placement of product as the needles or cannulas are withdrawn under low pressure also has value, as we do not want to overcome the systolic arterial pressure which causes the retrograde flow of product. Use of cannulas that are 25 gauge or larger has been shown to have benefit, as the possibility of the 27 and 30 gauge cannulas for being placed intraluminally is on par with that of sharp needle technique. And of course, an understanding of the vascular anatomy of the face, as previously discussed. Once arterial occlusion has taken place, recommendations currently are in favor of a high pulsed dosage of hyaluronidase into the affected area. This has been documented by De Lorenzi, and his incidence of necrosis and tissue damage has been markedly improved compared to other known studies. The question of whether or not aspirin, nitropaste, hyperbaric oxygen contribute to these remains questionable. So this is a reference that I will also provide to you at the end of this talk. I hope you found this session valuable and have learned some things that you can incorporate into your practice for, one, both improving results and the overall safety in your practice for your patients. If you'd like to explore this further, an excellent resource is a book which was written by Dr. Jameson and Dr. Chris Sudik, available through the Thyme Publishing Company, and I highly recommend that.